Welcome everybody, my name is Graciana. I'm a psychologist and also gerontologist. I'm a member of the AGA and elected treasurer of the IAGG. I'm now going to present the Conference of Economy and Long-Term Care, and the speaker will be Dr. Ludovico CARRINO. Dr. Ludovico CARRINO, PhD, is senior lecturer at the Department of Economics at the University of Trieste in Italy, and visiting professor at the Department of Global Health and Social Medicine at King's College in London. He's a consultant at Public Economics of Aging at the World Health Organization Co-Center and affiliated researcher at the C.A. Foscari University of Venezia. Dr. CARRINO is a public and health economist with a focus on economics of aging. His research aims at understanding how institutional contexts, such as pensions and social policies, affect inequalities in health and well-being across and within generations. His research has been published in leading journals in economics, epidemiology, and gerontology, such as Labor Economics, Health Economics, and the American Journal of Epidemiology and the Journal of Gerontology, as well as in books. Welcome, Ludovico CARRINO.
Hello, good morning, good afternoon, good evening, wherever you are. And thank you very much for having me at the 22nd World Congress of Gerontology and Geriatrics. I'd like to thank Professor Jose Ricardo Jauregui and Professor Nora Keating for inviting me here. It is a privilege for me to be here. Today, I'm going to, let's say, explain to you what are my perspective, economics perspective, on the challenges ahead on the road for healthy aging within the context of the decade of healthy aging, with a focus on long-term care, but not only on that. Before starting, I'd like to just say briefly a few things about me so that you know what is my context, my perspective. I'm a public economist, so I study typically public policies, social policies. I'm fascinated by this graph that shows that the amount of spending that governments do on social policy today guides us to a lot of analysis on how different countries look. But actually, we need to remember that none of this was existing just a few years ago, actually. And what I study is basically, what's the meaning of this? What's the use of social policies? Why do we need social policies? How do social policies improve population well-being and inequalities in the context of a push towards, let's say, a continuous increase in sustainable living standards in the long run? In this graph, this is just exemplified with the income per capita, but we know there's much more to well-being than income. So let me just tell you briefly what I do as a researcher, and I'll tell you where I work later. My sample of my research topics, I work on aging-related social protection policy. I typically study pension policies, social care policies, social benefits in a comparative perspective, mainly on Europe and the US, but I'm expanding this to a global perspective. I ask research questions that aim at, let's say, measuring the welfare effect of policies that go beyond the intended effect of policies. So I do policy evaluation. Mostly, I ask, for example, do non-health policies affect population health and groups that are not, or that were not originally targeted by the policy. I also ask, what are the social determinants of mental health, especially of mental health? For example, do working conditions affect your mental health, and how so? And I use causal analysis for policy evaluation using econometrics and econometrics methods. I work right now at the University of Trieste in Italy, and I'm visiting professor at King's College London. I am an external consultant at the WHO, the World Health Organization, the Kobe Center for Health Development. And I am affiliated to multiple research groups, and some of the results that I show you today come from the work that I've done with these wonderful research groups. This presentation stems from the concept of healthy aging as depicted by the recent reports at the beginning of the decade. Healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age. We know that there are 4 actions, and many others have spoken about this in this conference. First action, change how we think, feel, and act towards age and aging. Second action, ensure that communities foster the abilities of older people. Third action, deliver person-centered integrated care and primary health services that are responsive to older people. And fourth action, provide access to long-term care for older people who need it. I'll give you my perspectives from an economic point of view, mostly on action number 4, but you'll see that actually my approach touches has a lot to say also on many other actions, especially action 3 and action 2. So today I will cover 2 topics with 2 cross-cutting lenses. So the first topic I'll cover is whether we have or not, we don't, I think, an homogeneous definition of long-term care and the eligibility rules that enable people to access actually public care. And the second focus instead will propose a broader scope in policy evaluation, a policy evaluation that has a broader perspective onto the well-being of people, the effect that policies have on the broad well-being of people, also intergenerational well-being, and whether a policy actually affects the domain that should pertain to another policy. And the 2 cross-cutting lenses that I will propose is causality. I do causal analysis, and I think sometimes it's very important to focus on whether we can or cannot claim that something is causal, some relationship causal or not. And the second one, equity. Do policies affect people in the same way? We know they don't, and I think this is important to stress in order to have a richer and more complete welfare evaluation of policies in the context of healthy aging. I'm going to focus a lot on long-term care and its relevance. I think that you all know about this, assistance for the persons with reduced functional or cognitive ability, a very brief definition of long-term care. We know the need of long-term care is increasing, even though we will discuss what the need for long-term care is. Due to social, economic, and demographic change, there is pressure on public budgets. We know that public expenditure on long-term care will double in the next decade, will increase a lot. And we know that one important source, a fundamental source of long-term care are families and informal care. In the healthy aging context, functional ability is determined, let's say, is nicely represented by this diagram: meet basic needs, learn, grow, and make decisions, be mobile, build and maintain relationship, and contribute. I will wonder how this is translated in actual policies, in actual eligibility rules, in actual laws that have to identify individuals that have a reduced functional ability. And then, before starting, another diagram that I borrowed from the documents of the Decade of Healthy Aging published by the WHO. This nice graph that shows the continuum in life, let's say, and how the functional ability of people can be maintained even when the intrinsic capacity of individuals decline, if there is a supportive environment, and in particular long-term care systems, health systems, and other types of environments. I think I'll touch many of these points. I'll hope you enjoy. So the first observation I'm going to make, the first block of observations pertain to the definition of long-term care needs and the implications that different definitions for long-term care needs and therefore for long-term care services, the implication that this choice of definitions has for access to care and equity in access to care. And part of the results that I'm going to show you come from the INCARE project where I'm working on right now. at King's College London. So the use and expenditure of formal care, so formal services for long-term care, across the world, in this case, among the systems that are more mature, let's say, is very heterogeneous. As I'm sure you know, we can distinguish from home care use of formal care, institutional use of formal care. We know what is the average age of the users of formal care. But if we compare countries, as I tried to do in this slide, then we can notice a strong heterogeneity across countries. In some countries, home care is more prevalent than institutional care, but let's say in general, it is hard to explain in an easy way the difference we observe in the proportion of care users. You can see it ranges according to these data that are from 2015 from a proportion of 20% of older people using formal care in Switzerland, Israel, to around 5% in Czech Republic and less in Ireland and Slovakia, Poland, Portugal. This is just a selection of countries, of course, but that's an interesting picture to start from. And then the next point is on expenditure. How much do governments spend on long-term care? And also in this case, I'm not going to dig deeper on this point in this presentation, but it suffices for me to show the heterogeneity in the amounts that are spent on public money that are spent on long-term care services across countries that have mature welfare states again. So what is the lesson for those countries who want to develop a long-term care system? It's hard to draw a lesson from a picture like that. This picture shows the expenditure on long-term care according to the health sector and the health definition, let's say, but also there is the long-term care that is provided through the social care sector. And in many countries, there is a lot of overlap between these two sectors. There are comparability issues across countries for this reason. But anyway, we know that there is a lot of heterogeneity. So again, why do countries choose to spend such a different amount of money on long-term care? I can't answer this question, but I can provide you with the perspective that I'm following along a few other researchers, and I've been following for the last years, which is we need to look at an important feature of long-term care services, which is the eligibility rules and the way in which people actually have access to long-term care services. Access to long-term care services is not automatic. It is regulated by law. Now, from the literature in gerontology, for example, in social epidemiology, we can talk about, or in sociology, we can talk about need of care. We can talk about the conditions that people face in their lives for which they, typically physical conditions, functional limitation, functional ability, for which they need help. That's indeed the definition of long-term care. No, we said part of the definition of long-term care. We know that it is need of care rather than aging, above and beyond aging, the most important driver of long-term care demand. The point is, what is need? What is need of care? Let's say, when is a person in need of care? We can answer this question with some threshold using some list of tasks, some taxonomy to measure functional ability. For example, we could say anyone who has more than one or more limitations in activities of daily living has a need of care. This is also, say, an important example on this is the EU Aging Report 2015, where this measure is used to predict future demand of long-term care, but also in the most recent reports by the WHO, for example, on healthy aging. Examples like these are provided. The point is that in order to discuss the use of care and the availability of care through public providers, through public channels, we must not stop at wondering what is, let's say, from a philosophical point of view, need of care, but we must also look at what is written in the law, because we need to ask, what is the need of care according to the long-term care legislations? And if we look at the legislations, each long-term care legislation actually specifically defines a target population, the population of individuals who can get access to public support. And this support can be in kind or can be in cash. This need of care, this operationalized measure of need of care, is what matters for actual use or actual lack of use of formal care. This need of care is defined through assessment of needs and eligibility rules. I'll say a little bit about this in a second. There is no unique clinical definition for need of care. Just think about definitions of frailty, definition of disability, and all the complexity that carries along. And so we need to ask, how can the legislations, how can governments define a threshold for need of care? What type of threshold will they choose from the many available from the clinical literature, for example? So what we are asking is, if we want to talk about coverage for long-term care, developing a new long-term care and developing the new long-term care coverage, one of the main targets of the decade of healthy aging. Let's now look at the left-hand side of this slide. Instead of looking at what people can get, how much people can get, an overlooked part of this diagram, according to me, is who can get something. So how much let's say, what's the difference across countries in terms of how they evaluate the dependency of people, the qualifying condition, the indicators that are used, the way in which this is then reviewed, the definition of minimal level of dependency, that then is the trigger for actual use of public care. So assessment of needs and eligibility rules identify those who are in a condition of objective vulnerability in the legislation and thus can receive the benefit. The question is, how is this operationalized? How is this defined? And if countries choose different ways to define this type of objective vulnerability of need of care, what consequences do these differences across countries have in the access to care and inequality in access to care for people? As you very well know, this condition of need of care, this vulnerability, is undesirable, yet it is not directly observable in the sense that there is no simple clinical diagnosis, no simple clinical diagnosis, and which has led to a proliferation of definitions. I am conducting an ongoing research together with King's College London and other colleagues in the US and in Europe for a critical review of long-term care legislations. The first results have been published in 2018 in the book co-authored with Agar Brugevini, Cristina Orso, and Giacomo Pasini from the University of Venezia, Ca' Foscari, and other papers. And we have tried to quantify qualitatively and quantitatively these differences. Let me give you an example. So I've been reviewing actual legislations in countries. I've started from Europe, where countries have mature systems of welfare states and relatively mature long-term care systems. In each of these countries, there might be, for example, Austria, Belgium, Czech Republic, Germany, Spain, France, Great Britain, and Italy. There might be more than one programs, actually. For example, in Italy, each region has its own long-term care program, but also in other countries, like in Belgium, there are many long-term care programs. Yet other countries, like Austria, have one single major program. What are the components? What is actually evaluated in these programs in order to determine whether a person has access or not to long-term care? Well, ADL, activities of daily living, instrumental activities of daily living, but then other characteristics like cognitive limitations, like other special needs, like post-surgery needs. Is informal support included or not in these legislations. We can see from this slide, in most of these legislations, informal support is not included. Even though from this column, it might look that these systems are similar in the way in which they evaluate need of care. If you look at the eligibility threshold column, you can see that the actual definition of the threshold of need of care is very different and very difficult to compare across countries. 35 points according to this Belgian scale, 65 hours per month according to the new Austrian legislations, or in Spain, 25 points out of 100 of the Spanish scale. How do you compare this? The main outcomes used to evaluate vulnerability are the ADL, the IADL, and other characteristics, as I said. So it is comparable to the list of, but surely it's a subset of many of the list of the characteristics that are embedded in more complex measures of frailty and loss of autonomy in the clinical literature. Some legislations include only a few of those outcomes. Some other legislations include many more. There is another difficulty besides what I showed you, which stems from this lack of agreement, at least perceived by the policy, on what is need of care. And the second difference is in the weighting of basically the importance that each limitation has in determining need of care within each scale. For example, in the Pflegegeld program in Austria, ADL limitations are those which have, let's say, a very high weight in the sense that they carry a very high importance level in determining need of care. Among ADLs, difficulties in washing, difficulties in dressing, and difficulties in using the toilet have a higher importance than other activities of daily living. Among the non-activities of daily living limitations, there are some which still carry a huge role. For example, difficulties in cooking and difficulties in performing house tasks. There are other countries, like in the Przyspevek na Peci in Czech Republic, where ADL limitations are weighted the same, and IADL limitations, or anyway non-ADL limitations, are weighted the same. So each limitations count the same. In Italy, I'm just taking one example from a region, Friuli Venezia Giulia in the Northeast, where I am based now. Activities of daily living are not differentiating one from the other. And among non-ADLs, difficulties in cognition carry a huge role. So you have the completely different languages, not just because these countries have different languages, but because apparently they borrow from different perspectives of the clinical definitions of need of care. Some countries are more focused on activities of daily living. They target more severe conditions. So they establish eligibility for people who are limited in activities of daily living. Some other countries extend the definition of eligibility also to people who have even mild difficulties in instrumental activities of daily living. So this approach would include a pre-frailty state. Let's say it's an approach that suggests a prevention attitude. So to cover also people that have limitations in instrumental activities of daily living, but perhaps don't have difficulties in activities of daily living. And then there is the point on informal care. Should informal care, this crucial component of long-term care protection across the world, matter in order to decide whether someone should be eligible or not for public long-term care? And you have two different approaches, the carer-blind and the carer-sighted rules. In the carer-blind rules, informal care is not evaluated. In the carer-sighted rule, informal care is evaluated. And this address, let's say, new perspectives, adds new perspectives to our discussion because it raises new issues of inequity, vertical and horizontal equity. The point that I want to convey now is that long-term care needs means different things, even across similar countries. How do I try to quantitatively show you this? Well, I have used the shared data and the English longitudinal study of aging data from the UK. The share is the survey of health, aging, and retirement in Europe. I have used this data to compare individual health profiles. So in the shared data, we have, this is a micro data, so we have information on multiple Europeans, older Europeans, aged 50 or older. And we know a lot of characteristics of these Europeans. What we have done is we have matched the health profile of these individuals, the respondents to these surveys, to the local long-term care rules. And basically, we have asked questions such as, this Austrian person that I observe in the shared data, is this person eligible to the Austrian definition, according to the Austrian definition of long-term care? And then we have asked counterfactual questions. Would this Austrian person be eligible if we would adopt the German definition of long-term care, the British definition of long-term care, and so on? Let me show you a graph that shows what is the percentage of Europeans, older Europeans, that would be labeled in need of care under different definitions. This is the graph. Look at the gradient. This is a huge gradient. The percentage is the percentage of older people age 65 plus that would be defined as in need of care according to definitions that you can see in the horizontal axis. So according to the definitions of need of care that is in the legislation in Germany and also applied right now, the legislation that came into act in 2017, more than 20% of older Europeans would be in need, defined as in need of care. But according, for example, to the Spanish definition of need of care, only around 5% of older Europeans would be defined as a vulnerable. And the same, for example, for the definition in Italy, and even a smaller proportion if you use the Polish definition of need of care. And then there are many other countries in between, like Austria, France, the old German rules, and Belgium. So the way that we define the long-term care needs matter, because it means that we can basically have a wider or narrower demand for long-term care, for public long-term care. This graph shows you that even if you compare countries that might have similar eligibility percentages, let's say, potentially, actually, they don't cover necessarily the same people. They don't cover necessarily the same people. If we measure that in England, the proportion of people who are eligible is 15.3% of the older people in England, and in France, it's 15.1%, for example, and then we just compare these populations, we would observe that only a part of this population would be eligible to both definitions of need of care, but there would be a part of this population that is only eligible to the English rules, and another part that is only eligible to the French rules. So really, it's important to go and check the details on how these eligibility rules are defined. The OECD has given us a powerful graph in one of the recent reports that shows us how in different countries, the provision that is offered by public long-term care systems, let's say, goes to a very different way across countries in protecting people from catastrophic costs from long-term care, due to long-term care. This graph shows you the amount of costs paid out of pocket from a care user with a median income and non-net wealth, costs evaluated as a percentage of the income of this person after public support for different levels of needs. So look at the bar, the purple bar, which is the amount of cost in percentage of the income of the person that is faced by someone who has moderate needs, which means basically they are facing 6.5 hours per care per week. In some countries evaluated by the OECD, the out-of-pocket cost for this amount of needs for this person, an average care user with a median income and no net wealth, is very high. It can go up to 50% of this person's income. Of course, if you, and 100% for Latvia and Croatia, for example. And in other countries, this amount is very, very small. For example, in Germany, or in Finland, or in the Netherlands, or in Canada. If you look at severe needs, then the costs are always higher, let's say, and also in this case, you can see very different heterogeneity. Part of this difference is due to the fact that long-term care is defined in different ways. The need of care is defined in different ways. This graph shows you that if we change the definition of need of care in a given country, this could make a difference in terms of how many people would actually enter the world of public protection for long-term care. This graph shows you the blue bar is the current percentage of 65 plus individuals in the country who are receiving formal care. So for example, in Austria, it is in recent years around 10%. In Germany, it is recently around 12, 13%. In Italy, it is around a little bit more than 5%. We can predict, based on the work that I've shown you before, how would this percentage change if we would enlarge the eligibility rules in two ways. For example, we could change the rules, a long-term care reform that enlarges the eligibility rules in order to include anyone who has any limitation in activities of daily living. For example, this is the result of this is the orange bar. You can see that if you enlarge the population that is covered, you will increase the percentage of people that will use care. In some countries, a little bit more than others, but the orange bar is always larger than the blue bar, basically. If you also additionally include all the limitations in activities of daily living within the definition of need of care, you would reach an even higher population. Your potential demand would be even higher. For example, we predict that in Germany, currently the proportion of people using formal care is around 12-13%. This would increase to 14% if you cover all the ADLs in the eligibility rules, and basically to 15% if you would also cover the instrumental activities of daily living. I think this is relevant for the discussion that is ongoing within the decade of healthy aging on how to develop effective systems of long-term care. A summary so far before I move to the next point. The definition of need of care, although largely based on functional and cognitive limitation, is not homogeneous even across mature long-term care systems. This generates inequalities by law. The same person, a same individual, or two individuals with the same clinical profile could be treated in very different ways, have a very different likelihood of being covered by long-term care systems, and a very different protection from catastrophic costs, just because they live in different countries. Therefore, this, I think, is a point that leads us to discuss whether efforts are needed towards a more universal approach to long-term care definition. I'll say about this more about this in the next slide. There is much more heterogeneity across countries in the definition of long-term care than the standard taxonomies of welfare state would suggest. We know about the standard taxonomies of welfare state, the conservative model, the social democratic model, the liberal model. This analysis suggests differences are wider than that in terms of definitions of long-term care. There are many more overlaps and many more rank reversals with respect to what you would expect, let's say, if you just would look at the standard taxonomies of welfare states. And I have a paper which recently came out that discusses how social care systems actually do not match the standard classifications of welfare states in mature countries, mature welfare state countries. There are limitations to the analysis that I just discussed. We need further data, better data on eligibility rules, especially for caregivers, the support that is given to caregivers. We need harmonized microdata on the global aging population, not just on Europe and the US, of course. And there is a huge effort done, for example, by researchers at the Gateway to Global Aging, which you can visit at this website. But I think that this part of my presentation leaves us with three questions. I think one of the challenges ahead is answering these three questions. What constitutes long-term care? What are its objectives? What are the essential components of long-term care in terms of care packages for different degrees of needs? We do not have answers yet to this. I just discussed this point with respect to the definition of need of care. But you can imagine this is also relative and relevant to other issues that I mentioned in the second question. How do countries finance, organize, and deliver these components? And what roles and responsibilities do they assign to the public, the family, and the private providers? How much do services cost? And third, what are the consequences of such differences in provisions in terms of the effects on access to care, the quality of care, its effectiveness, and overall spending efficiency? Surely I don't have time to cover this point, but I wanted to give you my perspective on how much this is relevant. I think that one of the important challenges ahead is agreeing on a homogeneous set of definitions of long-term care. What is the minimum, the essential components of long-term care that we want to provide to the aging population. So on the second part of the second main topic I want to focus on, it's a briefer section, but I think equally important. And I want to talk about broadening the scope of policy evaluations for healthy aging, how important this is, and how relevant it could be to really enhance the narrative on healthy aging in this decade. I'm going to use a case study from pension policies, pension reforms. What do I mean by broadening the scope of policy evaluations? Now, policies are one of the main components of the environments in the healthy aging conceptual framework. I'm going to talk about the importance of accounting for or trying to capture, trying to measure the spillover effects of aging policies, but of any other policy that might have effects on topics relevant to healthy aging. First of all, I'm going to discuss the interaction across multiple areas of policy. A policy that targets, let's say, a policy that stems from one policy area, for example, retirement policy, might have an effect on areas that are actually the domain of another policy, for example, long-term care. There might be unintended consequences of policies, for example, unintended health consequences, and in particular, I'm going to talk about unintended mental health consequences of policies that have nothing to do with health to begin with. Or another spillover, the intergenerational impacts of public policy. So a policy that targets one generation, but actually ends up affecting the behavior or in a way the utility, the well-being of other generations as well. And finally, the equity impact of public policies. So who gets affected, how much, by how much by a policy. This is all very relevant for healthy aging. It also, I think, fits well into the conceptual framework of healthy aging. And then I'm going to use a case study from retirement policies, a topic which is relevant because it talks about the trajectories of work and retirement transitions of individuals. We are going to look at the interlinks between retirement policies, health policies, and long-term care policies very briefly. And I'm happy to discuss this more in the question and answers or in the future if you want more detail on my work on this. So very brief contextual point. pensionable age, the state pension age, the minimum age at which people are allowed to collect pension, has been increasing and will be increasing after a period when this ages were actually going down. From this graph, you can see both for men and for women, especially for women, if you look at the gradient of this line in the last 20 years, has been increasing. The normal pension age, the pensionable age, the age at which people can collect their pension. You see it has been increasing, especially for women, by a long amount of years. Policies, you can see from this graph, pension reforms have tried to enhance the employment rate of women and men after the age of 60. This diagram shows you that, especially for women, the reforms have been quite heavy. For example, we are going to evaluate this reform in the United Kingdom that brought the state pension age from women from the age of 60 in 2002 to the age of 2016. The age of 64 in 2016. But now it's even higher. It's at 65, 66. Future reforms will bring it higher. Now, what is the rationale for this second block, this spillover effect? We have, because of the aging process, we have pressure on policy. So policies develop pension reforms that prolong working lives, make, for example, women work longer. Now, if you look at the adult worker, age 50 plus, we can have this simplified version of his well-being, let's say, as made by three main dimensions: work, income, wealth, health, and then social activities and caregiving. There is much more. But let's say a typical evaluation of a pension policy would look at how this pension reform has affected the work decision, therefore the income and the wealth of this adult worker. In order to take a step forward, we ask, besides the known effects on employment and work trajectories caused by this reform, does prolonged working in older age because of the reform affect the health of older workers? Is there a health spillover? So the research question we are trying to answer, which we have answered in 2020, is: can a policy that incentivizes longer working affect the mental health of older women? Because the reform in the UK was targeting on women. There are many studies that study the impact of retirement on health. Most studies show little or no effect on physical health, but other studies find that there are effects on cognition and on mental health. The effect on cognitions of retirement on cognition are typically positive. On mental health, it is less clear. So what did we find? So we have evaluated the UK state pension age reform that increased the state pension age from 60 to 66. This reform was shown to have boosted employment rate among women by up to 10%, increase in employment rate. We use a causal identification method. We cannot just, so we aimed at looking the effect on health of working longer as a result of the reform. We cannot just compare the health of women who are retired and the health of women who are working, because the decision to work or not might be driven by health. So we need a causal identification strategy, which allows us to answer the policy evaluation question more precisely. So we use a causal identification method called difference in differences and data from the Panel Understanding Society in the UK, covering years from 2009 and 2018. What are our results? We find that there are spillovers on health. We find that the reform has made women actually work longer, but it has also increased the risk of clinical depression on average by 6 percentage points in the population. However, we document an equity effect. We document that the reform has led to higher health inequalities by job type, which was an unintended effect of this reform. Why do we find it? Why do I say that? Because we find that depending on the job that women have, for example, for women in high-strain jobs, jobs that have high physical or psychosocial demand and low control over skills, over timetables, for example, for those women, the effect of working longer as a result of the reform is much worse. And among this group, which is a an important group, is 1/3 of our sample of women that work in high-strain jobs, the risk of depression increases by 12 percentage points, as measured by a mental health scale called the General Health Questionnaire. So for many women in jobs like housekeeping, restaurant services, personal carers, salespersons, cleaners, machine operators, the reform has had a negative mental effect, which can affect their trajectories of healthy aging, of course. So is this a lose-lose-lose corner? Because of tough working conditions, prolonged working worsens health. However, women in low-pay jobs typically have also limited savings. They need to keep working in order to collect a higher pension, in order to earn a wage for a longer period of time. But also because of their lack of qualifications and skills, which goes back to the life course aspect of the healthy aging framework, because of the lack of qualification, their history, basically, it is harder for them to retrain, to find another job, or it is hard for the employer to redeploy them or to re-employ them elsewhere. Let's go to another, let's add another dimension. So we have the aging process that that triggers the pension reforms, which affects work, but it also affects mental health. Now we ask, can it also affect the other dimension of lives of people, like social activities that they do, and especially caregiving? And we know that informal care, family care, is a cornerstone of long-term care, and especially it is provided by a large part of informal care is provided by women, and women that are not far from retirement age, between the age of 50 or 55 and 65. These women are exactly those who are targeted by the retirement reforms, by the pension reform. So we ask, from a caregiver perspective, does prolonged working in older age as a result of the reform reduce the supply of informal care that this person would otherwise give to her spouse or her parents? And then another spillover, an intergenerational spillover. We ask, if the caregiver provides less care or more care, but especially if she provides less care, how does this affect the older parent, the care recipient? So we introduce another generation in the picture. We ask whether the older parent would receive a lower amount of care. So her or his care network would shrink as a result of her daughter, for example, working longer because of the pension reform. And this could have an effect in turn to the health, frailty, autonomy conditions of the older parent, to the income and wealth of the older parent, shaping the healthy aging trajectory of that person as well. So the societal question that we ask, do vulnerable older people receive less total care due to caregivers' prolonged working? And in a nutshell, so this research question too, which is answered by this paper by me, by Hena Fian from the Office of National Statistics in the UK, and Mauricio Avendano from the University of Lausanne and Harvard University. In a nutshell, this paper has these results. We find that yes, there are effects on caregiving on working longer. The results are the intuitive results, which are, however, empirically difficult to prove. For someone working 30 hours a week, which is the average amount of hours that the person working full-time in the UK works a week, we estimate that if this person continues to work that amount of hours because of the retirement reform, the pension reform, because the state pension age has been increased, this amounts to a reduction in caregiving by 330 hours a year, which is valued around £5,600 in a standard rate of £17 per hour using the 2015 prices, which is an important effect. It reduces significantly the probability of providing intensive care or meaningful care. Again, there is an equity effect. Specific groups are more affected by longer working. They face a stronger family work, let's say, conflict in this case. Instead of an opportunity, it becomes a conflict. Who are those that suffer more? Women engaged in jobs characterized by high physical or psychosocial demand. Again, high-strain jobs. Women in high-strain jobs give up care more when they have to work longer. But also women that are in sandwich or club sandwich care responsibilities. They have both grandchildren and parents. For these women, working longer means reducing care much more than for those women that are not in this care setting. So when then we look at the older person, we find that from the point of view of the older person, there is a negative effect on the amount of care that this older person receives. Because you could think, okay, the daughter works longer and she provides less care, but someone else steps in and basically substitute for this foregone care. For example, other informal carers or formal providers, private or public. We find that this is not the case. We find that the net effect on the amount of care that the older person receives when they have a daughter that works longer because of the pension reform is a negative effect. We find that the total support for older parents shrinks when their daughters work longer due to postponed state pension age. So parents who receive less help from their daughters do not receive more help from other family members or formal services as a counterbalance. What are the conclusions and policy implications of this? Now, there is a reduction in informal care for older parents when a pension reforms prolongs women working lives, and particularly for women in demanding jobs and the sandwich generation. This might trigger unmet needs for vulnerable older people, leading to higher future costs and worse aging, of course, less healthy aging. So policy implication, we argue this is an example when coordination should exist between policies, between long-term care policies and pension policies, for example. Policy instruments could be incentivize or give requirements to employers to offer work flexibility, for example, part-time options when workers have care responsibilities. Target policies to workers from high-demand jobs in order to understand that they face different mechanisms, different work-family conflicts, perhaps. So introduce caregivers' work-family conflicts also as part of the eligibility criteria for formal care that we discussed in the previous block. Whether the informal carer can provide care or not, has to work or not, what type of job she has, might be a part of the eligibility criteria for formal care. Let me now conclude this. In place of a conclusion, what is a simple economics framework for healthy aging? I tried to say it implicitly, but let me now state it explicitly now. So healthy aging, or aging in general, let's say, it's made of at least 3 dimensions. One is the health dimension, which is both a consumption good and an investment good. People invest in their health, but also consume their health in the sense that they gain pleasure from their health. So autonomy, frailty, and well-being. But then we have family and friends, the care network. We have income and wealth that can be used to purchase private long-term care insurance or pay out of pocket, of course. And the family, friends, and care network can provide informal insurance in the terms of exchange of time or exchange of money. In all this, the welfare state plays an important role and affects these mechanisms. And I think it's important to understand how the welfare state affects all of these mechanisms and not just those that were initially intended, they were initially intended to be affected. So to conclude, I would say understanding policy spillovers is core to healthy aging. I would argue to look beyond the policy's intended effect, beyond the intended outcomes and the intended populations, using causal analysis is important. Cross-policy spillovers that I have mentioned and we can imagine. Pension or retirement policies may not only impact the decision to work, but could also impact the decision to provide care. They might impact health outcomes, which in turn might lead to the demand and supply of care and work. We could ask a question like, is there a trade-off? Is the pension reform worth it, given the negative impact it has on non-work dimensions of aging, like health and caregiving? The intergenerational spillovers, the consequences on the behavior and outcomes of upstream and downstream generations should be accounted for. the equity effect. Public policy reforms typically have distributional impacts, even though they are intended to provide, let's say, improve allocative efficiency. We have seen the example of long-term care in the first block, provide access to care, or pension reforms, like make people work longer. But actually, their effect is unequal because of how the legislation is affected or is written, or because of how the mechanisms are different for people that have different characteristics. So distributional impact may also lead to health inequalities, as I tried to explain briefly, because of the distribution of social outcomes like income or use of care, and because they might have direct effect on health, like the pension reform that I discussed. So I would conclude this with 4 questions that are based on these two topics, broad topics I covered. Can we better link the macro to the micro to understand the impact of environments on health? These environments that are so important in the healthy aging framework: public policy environment, physical built environment, social environment, economic environment, political environment. Can we have better measures, better data, aggregate data and detailed data, perhaps at regional level, that characterize for as many countries as possible these environments and link them to the micro characteristics of people that live in those areas? Can we gather better macro data to exploit variation in public policy over time and across countries, to provide with the policy with causal inference that looks at the benefits and costs of changing retirement laws or education laws or long-term care eligibility criteria? Can we study the tensions and the opportunities that exist between the role of the state and the family, the familyisms theories, and the work-family conflicts at the macro level, at the micro level? And finally, can we have a contemporaneous, or should we have an historical perspective, a cumulative perspective of the effect of policies on people? We are looking so far at the contemporaneous, I am looking so far at contemporaneous effects of policies. But can we hope to isolate and identify the impact of life course exposure to various policies? When someone was young, some education policies were in place, some maternity leaves policies were in place, some employment, for example, conditions were in place, and then how has this affected the person since her youth years? I thank you for your attention, and I'm happy to discuss questions today or later on.
Hello.
Hello.
Welcome. Good evening, Dr. Ludovico Carrino.
Good evening to you. Good evening, everyone.
Good evening. It was a really pleasure for me to host you. I mean, it was a really nice topic that you were developing. And it's a pleasure for us to have you participating in this virtual congress.
Yes, I want to thank you, all of you again, for inviting me. It's been a pleasure. I would have liked to be there in person, but at least we had the first exchange of perspectives, I would say. Hopefully in the future there will be more. I welcome any question from the audience,
Yes.
Of course.
We will see if there's any question. Actually, there is. I have a question for you. That it says, Curreri Neiride. It says, we have just completed a study on the beliefs of families on caring for their older adults in Latin America and on CESW Africa. These families believe they are obligated to care. State laws often promote this familism. Where do we go from here?
Yes, I thank you for this comment. Very valuable, very valuable. There is an emerging literature that studies the normative component of culture. It's a very complex question. Where does culture come from? Can the government affect the family's culture, or is family's cultures which is affecting the government policies? I think perhaps trade of ideas across countries and across continents could be beneficial to try to put things in perspectives, that having someone that we love being cared for by a public, a nurse, does not necessarily mean that we neglect this person, that we don't care about her. I think that there is an emerging evidence on how formal care can complement informal care without taking away the value of informal care. But in a way, the availability of public provision or formal provision can improve the productivity of informal carers. And there is a bit of evidence on that. I think we could start from there. Let's say making people, discussing with people the fact that it's not about they have to stop caring, but just perhaps start to share a bit of time with a formal carer, which can perhaps improve the situation. I understand culture also. I live in Italy now, and we have a similar situation. I mean, it's a very normative point of view. Thank you for your comment.
I couldn't agree more, Doctor. Well, there is another question for you. Let me see. Savio Italo, there is usually a space of conflict between the social and the health and the lack of coordination. What opinion do you have? Do you discern?
Yes, I agree. Thank you for the comment. I think that we are moving in the UK, for example. There has been a push towards the integration of health and social care. Clearly, these are now seen as a lack of efficiencies in the public provision. This comes from an old view of the welfare state, which has been built very recently, because 100 years ago we didn't have any welfare state. So it has been built, and by building it, of course, we developed departments, and then now we realize that many overlap. I think that this is one of the main sources of inefficiencies and high costs for systems. And I think that in some countries, for example, in the United Kingdom, there has been an attempt to move forward. This is also a huge problem for data collection, by the way. We don't know exactly how much countries spend on long-term care, because some costs come from the health sector, some costs come from the social care. So I think this is a very important point.
Very interesting, Doctor. Very interesting. For the moment, I think we don't have another question.
Thank you all then.
Yeah, well, if so, I really want to thank you again for your participation. Hope to see you soon in further meetings. And
Yes.
It was really interesting chatting to you on your conference, of course. On behalf of the board, we'll thank you.
Thank you very much for sharing.
Bye-bye and good night.
Bye. Bye-bye.